Hello, hello, hello. Happy Thursday, everybody. Welcome to another round of VMR. It's really cool to one day think about how many times I will have said that before I retire. The goal is millions, hopefully. But today isn't one in a million. It really is today a one in a million event because we have two people in the VMR facilitation sphere and case presentation sphere who haven't done it before. And the first is our beloved Mariana, who has now become synonymous with VMR. Um, she pulled a what I call a Marino and Aisha, which has basically been doing teaching points and scribing constantly for the last month or so. But that's all just on the surface. Mariana is actually the is doing many things in CP solvers now. But the thing that's most memorable is that something that none of you have heard about. She came up with a absolutely brilliant idea that I have to keep top secret for now. But I will even top secret from the CP solvers team members who are all like, "What is he talking about?" But you will see. Hopefully, what do you think, Mariana? A couple weeks, maybe. Um, before her brilliance comes to shine, and she truly is an outstanding, outstanding clinician, outstanding learner, and truly very innovative and creative. And so, yeah, let's keep Deborah angry and irritated. Mariana, that's one of my number one goals in life. But we're really, really excited to again honor and celebrate some of our incredible team members who really shine, go above and beyond. And the way we do that is we say, come and discuss a really hard case in public. um, and let's do it together. But I'm sure Mariana will absolutely shine. Do you want to say a quick hello, Mariana, before we pass the mic to our new case presenter?
Yes, sure. Thank you, Rabbi, for your kind words. And yeah, I think we'll have this secret coming up in the next few weeks. And Deborah, please don't be mad at me. Yeah, and thank you for the introduction. For those who don't know me, I'm Mariana. I'm an international medical graduate from Brazil. It's my first time discussing here. And I'm nervous, but really excited about this opportunity. So let's go, Dr. Parmala. Do you want to introduce yourself?
Sure. Well, thank you, Mariana, and hi everyone. It's nice to meet you all. And I'm so excited to be here to present this case for the first time. And I hope you can all hear me clearly. So can I begin with
Oh
my
my
first
gosh,
topic?
no, not yet, not at all.
Oh,
You have to
okay.
tell us a little bit about yourself. Where are you calling
Oh,
from?
okay. Well, I'm from India, and
Okay,
I'm applying for neurology residency this year in the US.
amazing.
Um, and I'm working in the neurosurgery department right now. I'm not a
Oh,
neurosurgeon, just to clarify.
amazing. Where in India are you from?
I'm from Bangalore.
Bangalore, amazing. We've had many, many people from Bangalore join this space. How did you learn of this platform? How did it come across you, Parmala?
Funnily enough,
Yeah.
I actually saw you and Dr. Ravi and a few others
Yeah.
doing a mock interview.
Oh
That
no.
was presented in one of our observerships, and that's how I got to know, like, okay. And I discovered CPS VMRs just very recently. Otherwise, I would have been part of this much sooner. So yeah.
We're thrilled to have you join us. And of all the ways that you can discover some of the work I've done, I think the most embarrassing one is that mock interview. So um, it's a shame that that's how you started by getting to know me in particular. And I hope to undo what you've learned. My just for context for everybody, my whole job in that mock interview was to show people what not to do. And so I'll try I'll try to be on better behavior today. But thank you so much for joining us. And we're really, really thrilled to have you. I know you worked closely with the case review committee with Shema to have this case, and we're very, very excited for it. So please take it away.
Sure. Um, Jerking movements.
Ooh, what an intriguing chief concern, Mariana. When you hear jerking movements, what do you think of? What's crossing your mind?
Okay, jerking movement, right? So the first thing that I would like to know is for how long this is happening, if it's acute or if it started like a long time ago. Because if it's acute, I was thinking seizure going on right now, and but if it's for a long time, maybe we could have like um infection for like 1 month or 2 months, and if it's getting worse, it would also worry me. And I would ask for associated symptoms if this patient have fever, associated fever, because I would think an infection. And also if it's an of acute onset, I would ask for associated symptoms such as numbness and tingling, and if the patient is appearing with aphasia or dysarthria, because all of that could make me think in a stroke, and a vascular cause that's really important. We would have to rule out that because it could be life threatening.
I love your instinct, Mariana, to go from jerking movements to seizures. And at the end of the day, this illustrates to you how the chief concern is insufficient to understand the problem. It's in contrast to if somebody says shortness of breath or somebody says abdominal pain. You know what you have to start to do. This is a chief concern which may activate concern for seizure. It may activate concern for myoclonus, or it may activate concern for other movement abnormalities. So what your mind did was so astute is it assumed the most morbid hypothesis, which is what we should do. Always assume the scariest thing until you know otherwise. Though you often end up with the most common thing at the end, you should begin by assuming the most scary thing. And that illustrates how all of us think. And all of your thinking was around understanding this problem. So my reflection with you is to commend you for being smart about not mentioning specific diagnoses. We need to understand what this problem is and to understand what kind of movement disorder this is. However, there is a clue as to what kind of movement disorder this is, because it seems to be a movement disorder that actually moves the limb across a joint. When patients say that they have jerky movements, it implies that the movement disorder is strong enough to mobilize across a joint, which reduces the possibility that this movement disorder, for example, is a fasciculation or a tremor, and really prioritizes the possibility of a seizure disorder, myoclonus, or dystonia. So jerky means movement across a joint, which takes all the possible movement disorders that a person has, makes seizure the most morbid, myoclonus a possibility. Dystonic movements are not usually called jerky because they're sustained, and so there's not the waxing and waning feature, but those are the things that I'm thinking about as well. And I agree with you, we need a lot more information to begin to understand this problem. All right, Parimala, tell us more, please.
Sure. I really like the way the two of you, just expanded and started off with this case with just jerking movements. Well, so here goes the next part of it. This is a 72-year-old male patient who presented with 2 days of jerking movements in the right upper limb with 3 to 4 episodes per day, followed by heaviness and weakness of the right upper limb, so much so that he found it hard to grip things with his right hand. And he also had a new onset of dragging of his right lower limb. I can go on if you want me to.
Or whatever you had planned. Is this where you had planned to stop? Because I think that would be appropriate if you planned so. But whatever you decide.
Well, there's more, but I mean, maybe we could discuss a little bit here.
Yeah, I think that if you had planned to give us more in this aliquot, just proceed
Okay.
with your preparation. You already put so much work into it. There's no need to.
Okay. All right. So he also had a mild headache, And so his relative gave him one dose of aspirin, 150 milligrams, and rosuvastatin, 40 milligrams on the first night. And he was drowsy for 2 days, was sleeping a lot. And so on the third day, he went to another hospital where he was undergoing MRI. And during the procedure, he had one generalized tonic-clonic seizure, followed by 30 minutes of drowsiness. And so this outside MRI showed a well-circumscribed intraaxial mass lesion in the left post-central gyrus with minimal peripheral contrast enhancement and minimal bleed within the lesion. In our hospital, so we did an EEG which showed multiple electrographic seizures and left centroparietal slowing in LPDs. And we repeated the MRI 2 days later, and it showed an
Dr.
increase
Brahma,
in size.
are you I want to make sure that you're not proceeding with most of the information in the case. Is this just the second aliquot, or are you where are you along with your case?
Well, this is the second aliquot.
Oh
This is his
wow.
first admission. This is his first admission, so I
Oh
wanted
my
to.
gosh. Okay.
So I
We're
can
in for
stop
quite
here
a
if you
journey.
like.
Oh no, I just wanted to make sure that I didn't accidentally give you the wrong advice to complete the whole case. So this is
Oh
still
no.
Celica Aquat. Okay, all right, keep going, keep going. Whenever you're done.
All right. So I mentioned EEG, which showed multiple electrographic seizures and left centroparietal slowing and LPDs. So repeat MRI showed an increase in size of the lesion and increased blood products within the lesion. And contrast enhancement was minimal in the lesion margins. So MR spectrography showed no significant choline peaks. And then we did a PET scan, which showed increased FDG uptake in the margins of the intracranial lesion. And this was during his ictal period, that is during the first 3 days when he was having a lot of seizures. So the PET scan also revealed an incidental lesion in the right lung lower lobe. So after this, he was managed conservatively in our hospital. And then he had a history of fall on the face and nosebleed in the hospital while in the hospital. So there was no persistent active bleeding after that. And he was then discharged home with anticoagulants and anti-seizure medications. So I can stop here, or I could just complete the aliquot too. He came back to the hospital 2 days later with fever, nausea, and multiple seizures, followed by post-ictal drowsiness and weakness of right upper and lower limbs, impaired speech, and difficulty breathing. It's a lot, but I just wanted to.
I now understand what you were saying earlier about how aliquot 2 is tricky.
Yeah.
I understand that. And I think the truth is what you're taking us to is a very common scenario in real life medicine where a patient is going through a complicated diagnostic journey that isn't linear. In many cases in our VMR, we just go straight to the diagnosis. But I think by discussing such a rich aliquot in aliquot number 2, you're painting a picture that is not uncommon where patients have complicated diagnostic journeys and you don't know, well, the pathway isn't so straight shot. And so, Mariana, how when we didn't get the MRI and the EEG, what were you expecting the MRI to show before you got it? What do you think?
So with the first piece of information of the HPI, when Dr. Paramala referred that the patient had focal symptoms with like jerking movements in the right upper limb. So this is a sign that is a that is something focal happening in this nervous system. So the first thing that came to my mind was malignancy, because I thought about like something compressive in the brain and causing this focal lesion. And after the patient an MRI was performed, and then it showed a tumor. Then I started to think about meningioma or glioblastoma or metastasis. And then with the PET scan, it was probably a metastasis because there was a tumor in the lung. So I think that's what I thought during what Dr. Paramala was telling us. And now I think we have a different context because we have a patient with a tumor that is on anticoagulation and with anti-seizure medication, now appearing with fever. So I think we have a strong past medical history here, and now we have to think in other things, other associated things that is causing fever and headache.
I think that's absolutely superb. I'm very surprised that you were able to grasp such a complicated case with so much clarity. It's pretty impressive, to be honest with you. I'll just take a moment to clarify one thing with Dr. Paramala is what the reason was for the anticoagulant. Was the patient found to have atrial fibrillation, or what was the thinking for the anticoagulation for this patient?
Well, I actually was hoping that you would discuss it.
Yeah, sure, no problem.
Based on the presentation and the MRI findings, so we considered a bunch of differentials, and anticoagulation seemed to be the way to go.
Understood. Yeah, I think
Yeah.
that's very helpful. Thank you. Mariana, I think when a patient is presenting with a complication, like they're now febrile and we don't know what's going on, it's helpful to say, well, what are we dealing with, right? And you already started this conversation. We found a mass in the contralateral in the appropriate territory for the symptoms the patient was having. So our first connection is, do the symptoms map on with the imaging findings? And the answer is yes, because we see a peripherally enhancing lesion in the left post-central gyrus that makes complete sense as to why it would cause symptoms in the right upper and right lower extremity. We then were wondering, why are the symptoms intermittent? And we found that the patient was having seizures in that area. We also found that the patient was having some bleeding. The two most common complications of a cortical-based mass are infection, or seizure, and bleeding. And so the question really becomes, what is the differential diagnosis for a brain mass? And you took the leap, which was very wise, to say, let me actually make a differential diagnosis of a brain mass based on the systemic findings. So you said brain mass plus lung mass highly suggests cancer. I completely agree with you. But that is a leap that is not perfect. It's an educated guess based on probability. So the thing we know we have to explain is the brain mass, and the assumption you can make is that it's explained by the lung mass, but they may be true, and unrelated. So let's take 2 minutes just to talk about the differential diagnosis of a brain mass without any other clue. So if we're making a schema for brain mass, what would cross your mind in terms of categories of brain masses?
So I would think in primary tumors, and
Excellent.
after metastases, and after that I'm trying to associate something that can make me use anticoagulants in a patient. So I'm biased here. But honestly, I can't come up with anything that would make me because when I think in malignancy, I think in a hypercoagulable state. So yeah, that explains using anticoagulation in a patient with malignancy. But if there is a bleeding in the brain,
Yes.
I don't understand this part, so I think I would need some help here.
Got it, for sure. Let's talk about that next. The one question I have for you, and then we'll address that, is what do you think about a fever and brain mass? What does that make you think of?
It makes me think in abscess.
Exactly. So the most common causes of brain masses are by far cancers, which are more likely to be metastatic than they are to be primary in the brain. The most common cause of a non-malignant brain mass is an infection. And the truth is that those two things dominate our thinking in the vast majority of patients. However, there are two other disease categories to consider. The first is autoimmune diseases can cause brain masses. The most notorious are demyelinating diseases, such as acute disseminated encephalomyelitis, but other ones too. And counterintuitively, a subacute ischemic stroke can also cause a brain mass. That's a little bit to do with the fact that the brain has ischemic necrosis and liquefies. So a notorious mimicker of a brain mass is a subacute stroke. And that can be distinguished on MRI based on the location of the lesion and if the patient has prominent risk factors for a stroke. So the one possibility here that may merit anticoagulation is the hypothesis that the patient might have had a subacute cardioembolic stroke that over time started to look like a brain mass. Alternatively, you may worry about what you said, that the patient has a hypercoagulable condition that may be thrombogenic, but brain mass, cancer. Metastatic more so than primary, but don't forget to think about brain abscess. And then less commonly subacute stroke versus autoimmune disease, usually demyelinating. So the question then is, as you said, how does it help us that we also found a lung process? And I think what you said is true, Mariana. That makes cancer a very, very important hypothesis, with lung cancer metastatic to the brain being a very important consideration. The question, actually, let me just leave it at that. So that's an important consideration. But now we have a patient who's coming back who has a variety of new neurological complaints and also has a fever. So what do you think about that now, Mariana, with this complicated dimension?
So I think this is a tricky question because we can have like a neurological status causing this fever, like dysautonomy, brain dysautonomy causing the fever, but we also have to consider the infection. So I think the labs would help us here if we have signs of like increased white blood count, and yeah, but those are the main things that come to my mind when I think in this patient appearing a fever.
Exactly. I think the presence of a fever should make us really question what we're doing with. And we could start by saying, okay, I'm going to assume this person has lung cancer metastatic to the brain and now has a fever. So maybe there's a pneumonia that's causing all this in a patient who's vulnerable. Or you might step back and say, wait, how do I know he has cancer? Maybe he has a lung abscess and a brain abscess, and he has two simultaneous abscesses, right? So I think now it gets tricky because the patient is not following the path that we would expect in a patient with cancer. So we really have to be like, okay, do they have cancer and then a superimposed infection? Or has this been infection all along? Either the patient has a lung abscess and a brain abscess at the same time, or the patient has an endovascular process, something in the vessels, that has caused a subacute stroke that is infected, like endocarditis with a brain abscess, and also has some lung findings. So now the case has gotten very, very complicated, and we have to start by reassessing what is going on in the blood with the white blood cell count, and also what is going on in the brain and what is going on in the lungs. And there's two possibilities. It's cancer with a complication, or it wasn't cancer at all, and we were sitting on something else this whole time. Alrighty, well, thank you for that incredibly dizzying aliquot. I have a little bit of vertigo now. Let us know what you all obtain next in aliquot 3.
Oh, that was so fascinating. Right. So just to tell you that this is going to be like a Agatha Christie kind of a case where there's a little bit more in the past medical history which is not revealed right now, but I'm going to spring it on you later. So,
Thank you
um,
for the warning.
well, all right. So I'm going to give you the exam findings. This was during his second admission. So his blood pressure was 147 by 68. Heart rate was 80. Respiratory rate was 16. SpO2 was 89%, and he had a temperature of 100 degrees Fahrenheit. And he was a diabetic, so his GRBS was 240. He had mild exophthalmos. And then CVS, S1, S2, no murmurs. And RS, there were bilateral fine crepitations. And then per abdomen soft, non-tender. Then coming to CNS, he was drowsy but arousable to voice. He was confused but obeying commands. And his comprehension was mildly impaired with slowed speech and word finding difficulty. He was pausing and searching for words. He was also, he had paraphasias, a decreased fluency and word output. Repetition was, however, preserved. And his pupils were equal and reactive to light. And extraocular movements, there was a mild right horizontal gaze restriction known as nystagmus. And then a motor exam, right lower limb was 3 to 4 in strength out of 5, and right upper limb was 4 by 5, left upper and lower limbs 5 by 5. And he had a mild right upper limb apraxia. Then I don't have accurate information on the reflexes, but sensory, it was within normal, grossly normal. Cerebral was also normal. And then I can give you the labs if you'd like, or
Yeah, maybe we can just take one moment to analyze this exam because it's actually very interesting. And I'll just ask one clarifying question, which is the exophthalmos. Was that on the right side, left side, or both?
bilateral.
Bilateral exophthalmos. Okay. Alrighty, thank you very much. Mariana, have you come across the word exophthalmos? Or is this new for you?
Yes. Just correct me if I'm wrong, please, but it's a sign of hyperthyroidism, isn't it?
Yes, so hyperthyroidism is probably one of the most common causes of exophthalmos. Strictly speaking, what it means is that there's proptosis, or the eyes are coming out. And for sure that thyroid disease, especially in an older man, would be a consideration. But you have to think of what causes the eyes to come out of the orbit. So yeah, what are you thinking of in this case?
Oh,
What crossed your mind?
so I know that when you have like this exophthalmos, you have like glycosamine deposition, and it's usually caused by hyperthyroidism. So I'm wondering here if this patient can have like underdiagnosed hyperthyroidism contributing to the patient's symptoms. So, but we would like tachycardia. Yeah, we have tachycardia. No, not that much. We have 80 for heart rate. So we have like we would have like a moist skin, things like that. So I'm not sure if we're dealing with hyperthyroidism here, but I'm not sure if could be contributed some way.
Yeah, no, I think that this is a great opportunity for you to take what you know about exophthalmos and to like understand it. And I think you're doing a great job of really trying to see the most common cause. Does it fit? And the case here for hyperthyroidism is they're enough to check a TSH, but it's not going to be something that you invest all your money in, right? And that's because, as you said, the patient doesn't have many other features of thyroid disease. And so we can step back and say, as you said, that they're in hyperthyroidism, specifically Graves' disease, there's glycosaminoglycan accumulation behind the eyes. And that word accumulation is key. So basically any space occupying disease of the orbit can push the eyes out. So the eyes go into the eye socket, right? And so anything accumulating in that area can cause the eyes to pop out. And the thing can be as benign as glycosaminoglycans to as sinister as a cancer, to sinister infectious processes, and or in patients who've had trauma, the possibility of an orbital hematoma. So I think the question for us, Mariana, is to say, what is hiding behind those eyes and what is pushing them out? And the interesting thing is, how much time do we spend on that? Meaning, is this a unrelated finding to what's going on, or is it true and related? It's hard to know because patients with acute orbital disease that's space occupying often have the eyes come out, but also have chemosis or edema of the conjunctiva, and often have visual impairment, and a more prominent manifestation of this disease process. However, the fact that there is gaze restriction to the right, the eye cannot move all the way to the right, suggests that this disease process behind the eye is prominent. So not only are the eyes sticking out, it's also not moving. And it's important to remember that lack of motion of the eye may be because of a neuromuscular issue or a space occupying issue in the actual eye itself. So this exam introduces the complexity of whether or not we have a lung, brain, or orbital disease, or whether the orbital disease is true and unrelated. And that's the tension that I'm having. The simplest connection between a brain disease and an orbital disease is that the brain disease has evolved to involve the cavernous sinus right behind the eye, either in the form of an infection or in the form of thrombosis. So you can imagine left cortical brain, cavernous sinus, eyes come out. Or it could be that the disease is coming from the lungs or the heart, going to the brain and going to the orbits. I would be much more convinced of the eyes being involved in this acute disease process if there was also conjunctival injection and conjunctival chemosis, conjunctival edema. That would be as aggressive as this disease process is. So I'm not sure is a long version of this. And I think repeat cranial imaging with attention to the orbits will be very, very helpful. And just to summarize, the rest of the exam just really reinforces what we already know about the patient having a left-sided cortical lesion. I don't think there's much else with the speech and the weakness. So maybe we can get the labs and have you analyze those. But actually, before I do that, Mariana, any questions about understanding exophthalmos?
No, it was brilliant how you mentioned everything, and I learned a lot. Thank you.
Good. All right. Well, I'm sure we'll learn a lot more together. So, Paramala, tell us more.
Sure. So I'm gonna just mention key findings in the labs. So his serum sodium was 127, and total count was 25.5 K. Serum calcium, total calcium was 7.3. CRP was 26.75. ESR was 100. TSH was 1.3. And yeah, his urea was 35. And his chest X-ray showed increased bronchiovascular markings. Right. So we did a CT brain, which showed no increase in the size of the lesion compared to 2 days ago. And continuous overnight EEG monitoring showed left hemispheric slowing, no epileptiform discharges, and no electrographic seizures. I just wanted to know how many more minutes do we have
Yeah, I
in the
think
case?
maybe you can take us right before you reveal the diagnosis.
Right.
Yeah.
All right. So we did an MRI again, and this time it showed a left side parietal lesion with diffusion restriction and blood products with subdural collection, both of which were increased compared to the previous MRI. And this time the lesion showed a ring pattern enhancement with adjacent leptomeningeal enhancement and mass effect. And there were a few tiny areas of diffusion weighted restriction, DWI restriction, in the right cerebral hemisphere as well. So,
Okay, terrific. Wow. So Mariana, how are you interpreting this MRI? What is it making you think of?
Okay, so we have embolic hypothesis of embolic infarct. So this is what concerns me the most here. And also ring pattern enhancement. We have a good mnemonic for ring enhancement and in the MRI. And I remember that just taught us about the Dr. Magic mnemonic for ring enhancement. And we have leptomeningeal enhancement as well. So I don't know what to do with this information. I just would like to say about the hyponatremia that was I have a hard time understanding and memorizing hyponatremia, and before this case I was, oh my god, I hope there's no hyponatremia, and here it is. So, but just one thing that I learned that I think it's really, really important when we have hyponatremia is that when you have an important hyponatremia like that, like 127, this patient was probably on hyponatremia for a long time, because if it was acute, the patient would have symptoms like more clear symptoms of hyponatremia. And the first, I think we should check like serum osmolality and after the urine osmolality to be sure. But in this context, I would be really worried about SIDH, and we have a lung mass that could be causing this SIDH. And but we also have, if we have the patient had, for example, a pneumonia, we also could have SIDH. So I think it's not really helpful here. And now we have this increased white blood count, so an ESR of 100. So yeah, I honestly don't know where to go, but I still think in malignancy mainly because of the hyponatremia, but I think we can rule out infection because of the increased white blood count. And this MRI with a hypothesis of embolic infarct also makes me really worried about this patient.
Yeah, I completely agree with you. I think that this case is very, very tricky and very unfortunate. And I think whenever you have a brain mass, your pretest probability of cancer is so high that it takes a lot of other findings to move them away. And I hear you in vocalizing those findings. The patient has a very high white count, has a high fever, And also, I'll add in one other thing, Mariana, that I think a lot of people find very helpful is evolution over time. In general, cancers progress less quickly than infections. So in many instances, when we're trying to figure out, does this person have an infection or cancer, we often get repeat imaging. And if the growth is very quick, we prioritize infection because infections tend to grow faster than cancers, though that's not always true. So if we start with a simple formulation that this person has a brain mass prioritizing cancer, we then start to say, what does the accumulative evidence of not only fever, but also white count and very rapid growth? Remember, Mariana, this story is days old. He had symptoms for 2 days. And a few days later, now he has lesions everywhere, right? New large lesion in the left parietal region, right cerebellar hemisphere. This disease is progressing faster than most cancers progress. And so the question is not just what is it, but where is it coming from? And originally, we saw some PET CT findings lighting up the lungs, but now we see that there is a shower of emboli, really reminding us of Anmol's case and Tansu's recent recap of that case, that we should really think about an endovascular source of this process. Of course, this could be cancer with merantic endocarditis. But if we reframe this as a patient with brain masses with embolic phenomenon, all of a sudden infections become more likely. And even when you then zoom in on the MRI features also suggest cancer because of the combination of ring enhancement and diffusion restriction. This is advanced neurology, but that combination is more suggestive of infection. So it depends on what we frame this. If we remain stubborn to the idea this is a brain mass, probably cancer. But if we update our thinking to say that this is a embolic disease to the brain, as evidenced by the multifocal predominance of this signature on the disease, we might start to say embolic disease plus high fever plus high white count. Is this an endovascular infection, of which endocarditis is the most important and most common? And is this patient bleeding because he has mycotic aneurysms that are oozing and bleeding? And that hypothesis is reinforced by the subdural collection and by the MRI findings of ring enhancement with diffusion restriction. That's very suggestive of a brain abscess. So for me, this case has become all about trying to understand what is happening in his blood vessels and his heart. And my priority would be an endovascular infection. And so endocarditis is the most important consideration to have, which was the case and answer in Anmol's case. But I'll ask you one question, Mariana, around that is, what infections do you associate with diabetes? What unusual infections do you generally associate with diabetes?
No, the first one that comes to my mind is the mucormycosis, but it would appear like differently. I don't know if it would appear with like a brain lesion, like only brain lesion without any signs in the skin and in the patient's face.
Exactly right. I think this case should make us think of mucormycosis for sure. but mucormycosis that causes cerebral abscesses is usually in neutropenic patients, not in diabetic patients. So most of the time, mucor is in the rhinocerebral mucor, not this mucor. So I think that we really have to go back and say the process is likely involving some kind of bad vessels this person is having, and endocarditis should be the leading consideration. But there's one thing think we need to revisit, and revisit strongly. And this is requiring some complicated thinking. That's why I asked Paramala to end a little bit early, because I think we have a couple minutes to discuss this, Mariana. So now I want you to take a deep breath, and we're going to go somewhere else, very far from what we were talking about, okay? Look at the oxygen saturation, 89% on room air, 89%. Why do you think a patient has oxygen saturation of 89%? Weird, right? No clear answer so far. Let's go back and review one small piece of history that we initially ignored: nose bleeding. Remember, we were talking vascular now, and thinking about blood vessels. And so whenever you're starting to think about an endovascular process, you have to go back and say, has the patient given me any blood vessel clues? So let's just start with the nosebleed. Have you thought of what are the common causes of patients having epistaxis? What have you seen in real life?
The first thing that come to my mind is like glucocorticoid use, like topical glucocorticoid use causing epistaxis, and also okay, so after you said all of that, I started to think in a specific diagnosis that I think we should not do that, like go directly to the diagnosis, but thinking in epistaxis associated with hypoxemia, and it makes me think in vasculitis, because it's something that is like it's causing nose and lung issues at the same time, and also brain issues at the same time. So I would go for that, but I still thinking in epistaxis, and other causes of that would be like yeah, glucocorticoid use, vasculitis, and I don't know if that I probably forgetting something important here.
No problem at all. I think you're thinking of the most common causes, and you're absolutely right. Irritation from glucocorticoid use and irritation from environmental pollens is absolutely superb. What if you learn that the patient has epistaxis and has hypoxemia in their lungs? One thought would be that they have AVMs in their nose that are bleeding, and AVMs in their lungs that are causing shunting. Have you heard of the diagnosis of HT, hereditary hemorrhagic telangiectasia? I think it's also called.
Yeah.
What do you know about that diagnosis?
Oh, to be honest, I only know that it's in a part of the first aid for step one, like with a bunch of other causes of autoimmune disease and weird things.
Yeah. Hereditary telangiectasia is basically known by everybody for AV malformations, and that's all we really know about it. But the truth is, I actually have a lot of patients with it because UCSF is a referral center for HHTs. I don't have a lot of patients, but I saw many patients in my residency because a lot of them come to the UCSF hospital for tertiary care. And you learn that it is an autosomal dominant disease, characterized by one very universal thing, and that universal thing is recurrent epistaxis. But the reason to think about it in this patient is not because the patient has epistaxis. Epistaxis is only 1% of epistaxis is HHT. But whenever you're worried about multiple brain abscesses occurring from a distant source, you have to wonder, why is this patient getting brain abscesses? And one possibility is the patient has AVMs in their lungs. So why is AVMs in the lung really, really bad for the brain? The lungs filter out many things that come into the body, including infections. And AVMs in the lung remove the lung's ability to be able to protect the brain from small amounts of organisms that make it into the body the whole time. The combination of epistaxis and hypoxemia is concerning for the possibility that the patient may have AVMs, though the much more common combination of epistaxis and hypoxemia is usually aspiration. However, when you factor in that the patient has brain abscesses, you start to say, wait, hold on. Is the patient having a portal of entry into their brain more easily than most people? And so that's when you wonder, what is the status of their heart? Here, heart rate normal, blood pressure normal, no murmur, and presumably by day 6, 7, no growth on blood cultures, right? So the heart may not be our clue. The clue may be, wait, epistaxis, hypoxemia, lung lesion? Was that lung lesion an AVM in the lungs? So what am I confident about? I'm confident that this patient has infections in their brain for reasons we talked about earlier. The pattern of infections appears to be coming from inside the body in a very vascular way. And the question is, what is that vascular disease? And the clues so far to me are hypoxemia without obvious reason, and this. And that combination is making me worry the patient has AVMs, causing them to bleed in their nose and bypass their lungs, setting up shop in their brain. That is a very unusual and rare diagnosis to make, but we can all be much better at recognizing it because all patients with HHT don't just have a little epistaxis. If you talk to this patient, and if they have the diagnosis, they will tell you they have epistaxis so often and so frequently in the morning and at night, in summer and in winter. And if you look very closely, you will likely see AVMs in their lips and on their hands. So my advice for this case, Mariana, is blood cultures, echocardiogram, much more common, but with some simple physical exam observations of the mouth and of the lips, you may uncover a very sinister disease that this patient has. I'm biased by the fact that this is VMR, but I think there's enough evidence here to pursue all vascular hypotheses, common ones like endocarditis, and uncommon ones like your first aid favorite mnemonic. Any questions or any thoughts about that, Mariana?
No questions at all. I just have to study a lot of AVMs. I'm really interested about that.
Yeah. Well, maybe you have to study it, or maybe you should ignore what I have to say. It depends on what Dr. Paramala says next. All right. Please tell us, what did you all think, and how did you settle this very complex and very interesting case?
It's really amazing the way you two just untangle this case and came to the correct diagnosis. Well, so I'm just gonna mention his past history, the one that I left out previously. Before that, he had a profuse nasal bleed in his second admission. And that's when his past history of similar complaints was uncovered. He had a history of epistaxis, which is pretty much alternate on alternate days, 4 to 5 episodes each time. And there was a family history of nasal bleed, epistaxis as well. Grandfather, father, brother, sister, and daughter. So yeah, so we did a CT pulmonary angiography, and the incidental lesion in the PET scan did turn out to be an AVM. And the pus culture of the lesion, we did a surgery to remove the abscess. So the pus culture came back positive for Streptococcus intermedius. And he also had AVMs in the GI tract and the liver. So the final diagnosis is, of course, left parietal abscess with frontotemporal empyema and right lung middle segment AVM, and due to possibly hereditary hemorrhagic telangiectasia.
Paramala, this is an unbelievably educational case, and I think that it inherently is a very educational case in many, many ways. But I think everyone who's watching is you're showing us just the power of how you chose to tell the story. Because if you had just told us and given us this diagnosis as part early on, the case would have had much less teaching in it. And I think this is the power of becoming a clinical reasoning person, is to recognize how can I get more out of these cases and make them more educational. And I think the fact that you chose to tell the story in this way really maximizes the learning. And so this is a very, very hard case to take care of in real life, but it might be even harder to turn such a complicated case into an actionable and worthy reasoning exercise without overwhelming the group. So this was fantastically constructed and really, really educational. Thank you very, very much.
Well,
And
thank you, and thanks to Seema too. I like that there were a few red herrings in the case, so it was quite fortunate that way.
Yeah, no, for sure. And Mariana, I can't imagine being in your shoes and being before residency and having to discuss such a complicated case. And I think that honestly, your ability to be confident about what you know and how quickly you made those connections initially, but also I think for most people, just modeling the fact that none of us know everything and we're all trying to learn and grow, and being honest about that your knowledge for HHT is limited, and and that it's going to grow a lot, I think is so empowering. And that's what this is about. This is not about knowing the answer. It's about being honest about what you know and what you don't know and how you're going to learn and grow. And I really admire you for vocalizing that so well. I'm curious, how do you feel now? What are you left thinking of in this case?
Oh my God. Thank you so much, Dr. Permal. It was such an amazing case. And it was so interesting to see, because whenever we were discussing Dr. Permal, I was trying to hide that she was like liking what we were saying and trying to give no clues about it. But it was so, so nice. And in the beginning, I was so nervous, but afterwards, I was not even nervous anymore. I was just trying to think and trying to connect the dots and trying to gather all the knowledge I had in neural, that is not that much, and trying to put in our case. So it was a really, really good experience. Thank you for this opportunity. And I'll have to dip my studies in AVM right now.
Yeah, I think knowing you, I think you're gonna become an expert in this diagnosis in no time. Really, really wonderful job, and I already look forward to the next time we get to discuss together. Really well done. All right, Gia, you have the enviable task of summarizing our teaching today. Take it away, my friend.
Yeah, such an amazing case and discussion. I was already like got a lot of education in how to differentiate all of these things. And so first, for this case, we got this patient has a chief complaint of jerky movements. And talking about jerky movements, first we need to rule out some scary things like stroke, and then think about common things. And also we definitely want more information about how this jerky movement is like to help us differentiate it from trauma. And also like time course and associated symptoms can definitely give us more information. And then for jerky movements, several possible etiology is seizure, myoclonic, and dystonic, and some movement abnormality. And then from the patient's history, we know and the imaging finding, we found this patient has some focal neurological symptoms, and these symptoms is consistent with what we found in the MRI. And there is a brain mass. For the differentiation of brain mass, we consider tumor, no matter primary or metastasis, and infection, and also autoimmune disease, mainly demyelin disease and subacute ischemic stroke, which we should pay attention to the location of this brain mass and the associated risk factors. And then the patient's history also revealed fever and lung lesion. And so our thoughts kind of lead to several possibilities, like is it the cancer with the infectious complication? Is it IE? Is it like both infection in the lung and brain, or is there any other possibilities? And then from the physical examination, we found very interesting finding, the exophthalmos. So the exophthalmos is related to caused by the space occupying disease. And for the benign cause, most commonly could be grave disease, especially in older people, caused by the glycogen accumulation. And also there is other possible cause like cancer, infection, and trauma lead to orbital hematoma. And the patient also has the gaze restrictions. So we may think about is this caused by the space occupying disease or caused by some neuromuscular etiology. And so for this whole picture, the brain funding, lung funding, and then the additional orbital funding, let us think, is this any brain process involved the cavernous sinus and then lead to the orbital funding. And then according to the labs and the repeated imagings, we got more information, like this patient has a very quicker progress and a high white blood count and the embolus funding in the MRI. So we are very questioned, is this infection or malignancy? And at that point, we are more tend to infection, because this diffuse involvement and the shower of emboli in the patient's brain. And then we may think about the endovascular source, like just IE or myelinitic related to malignancy. And very interesting, this patient also has a low oxygen saturation and a history of nose bleeding. So from the epistaxis, we discuss a lot of what may cause epistaxis, like some irritation from dry air, from medicine, or some fragile vascular condition. But combining in this picture, the low saturation, nose bleeding, and the lung brain lesion, it all kind of lead us to a possible very unexpected disease, HHT, hereditary hemorrhagic telangiectasia. So like Rabih gave us a lot of education. It is autosomal dominant disease, and very unique things about this disease is it is recurrent epistaxis, and the AVM can found in the patient's lung, and also the AVM can impair the lung function in cleaning some pathogen, and therefore lead to like a spreading brain abscess, like in this case. So the further information we want to get is a history of nose bleeding and any family history, and also we want to find is there any AVM finding in the physical examination, like in the lips and hands. And so the final diagnosis actually exactly prove our guess, and it is HHT. A very amazing case. That's what I learned today. Thank you so much for this case and amazing discussion, Rabih and Mary. Yeah.
That was amazing. It was so linear and such a great walkthrough. I love that you didn't skip over the initial part, because I think the initial part of like mapping onto the brain mass was just as key, and the signal versus noise was really tricky. And I forgot that the ex-ophthalmos was even there. And now I know that Pramala was tricking us a little bit, but I'm glad we didn't fall for that trap. All right, y'all. Thank you again for such an amazing hour, and really hope you have a wonderful rest of your day. Bye.